Welcome to this video on common and serious pitfalls in the emergency department. This teaching deck explores the recurring diagnostic, cognitive, and systems-based errors that lead to patient harm in acute care and how you can guard against them. The content of this video is organized into 8 distinct domains, covering a total of 31 clinical pitfalls, ranging from cognitive and systems-based issues to specific medical specialties like cardiology, neurology, and trauma. It is important to recognize that most serious errors in the emergency department are not knowledge failures, but rather cognitive biases or systems-related factors. Each pitfall in this video follows a clear structure, identifying the trap, explaining why it happens, and providing practical, protocol-agnostic safeguards. We begin with Section A, Cognitive and Systems-Based Pitfalls. These are the errors that occur upstream of every diagnosis, often resulting from failures in thinking processes or system design. Pitfall A1 is premature closure or anchoring. This occurs when a diagnosis is accepted too early, leading the clinician to discount subsequent data that doesn't fit the initial label. To avoid this, always actively generate a worst-case alternative and ask yourself what findings might prove you wrong. Pitfall A2 is confirmation bias in the familiar patient, often called the frequent flyer trap. Familiarity can lead to a shortcut where previous records substitute for a fresh assessment. Guard against this by re-examining every patient as if it were your first time meeting them. Pitfall A3 is diagnostic momentum and inherited labels. This is when an initial assessment from triage or EMS is carried forward without independent verification. Always treat inherited diagnoses as hypotheses to be tested, not facts to be accepted. Pitfall A4 concerns handoff and sign-out failures. Critical information, such as pending results or instructions to reassess, is frequently lost during shift changes. Use structured handoff formats to ensure that every patient's status and necessary follow-up are clearly communicated. Pitfall A5 is the failure to reassess after the initial workup. Many clinicians rely on a single snapshot for disposition. Remember that a patient's trajectory can change, and serial reassessment is essential before any discharge. Moving to Section B, we look at cardiovascular and vascular pitfalls. These are often high-stakes situations where minutes matter, and an early, reassuring test result can dangerously mislead the clinical team. Pitfall B1 is acute coronary syndrome presenting with a normal or nonspecific ECG. Never allow a single ECG to exclude ACS if the clinical history is concerning. Use serial ECGs and biomarkers and maintain a low threshold for repeating tests if the patient's symptoms persist. Pitfall B2 is aortic dissection being mistaken for ACS or musculoskeletal pain. Because dissection is rare, it is often missed. Always consider dissection in patients with atypical chest pain and perform bilateral blood pressure checks before initiating anticoagulation therapy. Pitfall B3 is pulmonary embolism in the atypical or low-risk patient. Don't let a normal oxygen saturation or lack of classic risk factors lower your suspicion. Use validated decision tools and consider PE in cases of unexplained syncope or tachycardia. Pitfall B4 is high-risk syncope being discharged as vasovagal. While vasovagal syncope is common, failing to systematically screen for cardiac or structural red flags is dangerous. Always review the 12-lead ECG personally for conduction abnormalities. Finally, Pitfall B5 is cardiac tamponade masquerading as heart failure or sepsis. In patients with malignancy or recent procedures, shock symptoms can be misattributed. Early point-of-care ultrasound is crucial to differentiate obstructive causes from fluid-responsive states. Moving on to Section C, we focus on neurological pitfalls. These are cases where a normal initial scan or common mimic can dangerously lead clinicians to exclude more serious, rare pathologies. Pitfall C1 is missing a subarachnoid hemorrhage when the non-contrast CT is negative, particularly outside the early window. Don't let a normal CT stop you from pursuing lumbar puncture or CT angiography if the clinical history of a thunderclap headache remains concerning. Pitfall C2 involves misreading a posterior circulation stroke as peripheral vertigo. Avoid relying solely on symptom description. Utilize structured bedside oculomotor exams, like the HINTS assessment, and maintain a low threshold for neuroimaging when central features are suspected. Pitfall C3 is discharging a TIA patient without proper risk stratification. Symptom resolution does not mean the patient is at low risk. Ensure urgent, often same-day access to carotid imaging and cardiac assessment for these high-risk individuals. The Pitfall C4 is missing cauda equina or spinal cord compression by labeling symptoms as mechanical back pain. Always actively screen for saddle anesthesia and bowel or bladder dysfunction in significant back pain presentations. This is a time-critical surgical emergency. In Section D, we address abdominal and pelvic pitfalls. This domain is often shaped by age, sex, and atypical presentations that don't match textbook descriptions, requiring a high degree of clinical suspicion. Pitfall D1 is misattributing an ectopic pregnancy to other GI or urinary causes. Always perform a pregnancy test for any female of reproductive age with abdominal pain. Never assume an intrauterine pregnancy without ultrasound confirmation. Pitfall D2 is mesenteric ischemia presenting as pain out of proportion to exam. An elderly patient with a soft abdomen and severe pain should be considered high risk, especially with vascular disease. Pursue early CT angiography rather than waiting for classic peritonitis. Pitfall D3 is mistaking testicular torsion for epididymitis. Because epididymitis is more common, it's easy to overlook torsion. Treat all acute scrotal pain as torsion until proven otherwise, particularly in children and adolescents, and consult urology urgently. Pitfall D4 is missing appendicitis at the extremes of age. Children and the elderly often present with vague or atypical symptoms, lacking the classic migratory pain. Maintain a low threshold for imaging in these groups to avoid dangerous delays. Section E covers infection and sepsis pitfalls. The danger here lies in the body's compensatory mechanisms, which can mask severe illness, leading to dangerous delays in treatment. Pitfall E1 is missing early sepsis when vital signs appear normal. Remember that young, fit patients can compensate effectively until they suddenly decompensate. Look beyond just blood pressure and heart rate. Monitor mental status and lactate levels for early warning signs. Pitfall E2 is misdiagnosing necrotizing soft tissue infection as simple cellulitis. Watch for disproportionate pain or rapid progression. If these signs are present, do not wait for lab results. Initiate surgical consultation immediately, as timely debridement is life-saving. Pitfall E3 is failing to consider bacterial meningitis in atypical cases. The classic triad of fever, neck stiffness, and confusion is often absent, especially in the young or elderly. When faced with unexplained fever and mental status changes, maintain a high index of suspicion. Section F explores pediatric pitfalls. These are specialized cases where physiological differences and communication barriers demand a unique approach to ensure children receive safe, appropriate care in the emergency department. In Section F, our first pitfall is failing to diagnose a serious bacterial illness in a well-appearing febrile infant. Because neonates can mask significant infection while looking healthy, reliance on Gestalt alone is insufficient. Always apply structured, age-based risk stratification and ensure reliable follow-up. Pitfall F2 is missing or under-considering non-accidental injury. It is easy to accept a caregiver's account at face value, but you must assess whether the injury mechanism matches the child's developmental stage. Always perform a complete physical exam and utilize your institutional child protection pathways when concerned. Pitfall F3 is labeling vomiting or abdominal pain as simple gastroenteritis while missing DKA or a surgical abdomen like intussusception. Never assume a benign course. Use point-of-care glucose checks and maintain a low threshold for surgical consultation, especially in infants with bilious vomiting. Section G covers trauma pitfalls. These center on distraction, when an obvious, painful injury diverts your attention away from a quieter, potentially more lethal, internal problem. A systematic survey is your best defense. Pitfall G1 occurs when a distracting fracture hides blunt abdominal or pelvic trauma. Do not let an obvious limb injury end your assessment. Complete a systematic secondary survey and treat mechanisms like seatbelt signs or steering wheel contusions as independent indicators for further imaging. Pitfall G2 is missing an occult pneumothorax or failing to monitor for tension physiology. If a pneumothorax is identified on CT, it is clinically significant. Monitor ventilated or transported patients closely. Tension is a clinical diagnosis. Do not wait for repeat imaging if the patient is deteriorating. Pitfall G3 involves cervical spine clearance errors in the elderly or patients with ankylosing spondylitis. Standard rules may not apply to rigid or osteoporotic spines. Maintain a low threshold for CT imaging rather than relying on clinical clearance in these high-risk populations. In Section H, we address disposition, documentation, and communication. Even with an accurate diagnosis, errors in communication or patient instructions can result in significant harm after the patient has left the department. Pitfall H1 is discharging a high-risk patient without adequate safety netting. Generic instructions are often forgotten. Provide concrete, diagnosis-specific return precautions and use teach-back to confirm the patient truly understands when to come back to the emergency department. Pitfall H2 is an inadequate against medical advice or refusal process. AMA documentation is not a liability shield. It is a clinical process. Always formally assess capacity and document a clear, shared discussion of the specific risks the patient is accepting by refusing care. Pitfall H3 is a failure in the closed-loop follow-up of results. If a patient is discharged with pending tests, you must have a reliable system in place for the critical result to reach someone who will act. Individual ownership of these results is non-negotiable. Pitfall H4 involves using ad hoc interpreters, such as family members, during consent processes. Nuance and understanding are easily lost. Always use a qualified professional interpreter to ensure the patient is genuinely informed and that safety netting is clearly understood. This video draws from established emergency medicine literature, including Rosen's and Tintinalli's textbooks, alongside guidance from the ACEP, RCEM, and the WHO. These sources inform our approach to minimizing error and maximizing patient safety. Finally, remember that this deck is a teaching tool, not a clinical protocol. Local guidelines always take precedence. Use this information to sharpen your clinical judgment and foster a culture of safety. Thank you for your commitment to excellence in emergency care.